Wound infection and cesarean delivery. Is it not loud enough? Okay, is that better? Okay. The title, Preventing Wound Infection and Cesarean Deliveries, the ABCs. My presentation this morning is divided into 3 sections. The first, antibiotics administered preoperatively. Second, the surgical site preparation. And third, closure techniques. Following each section, I will review the current policies and procedures at the University of Maryland. Pregnancy-associated infection is a major cause of maternal morbidity worldwide. In the United States, it is the 3rd leading cause of maternal mortality. Surgical site infections complicate anywhere from 3 to 18% of cesarean deliveries and occur in up to 30% of obese patients. They are associated with substantial morbidity, prolonged length of stay, admission for additional antibiotics, and readmission to the hospital. In a retrospective cohort study at Barnes Jewish Hospital, this was designed in order to determine the attributable costs associated with surgical site infections, including endomyometritis as designated by EMM on the chart. A total of 1,600 women who underwent low transverse cesarean section from July of 1999 to June of 2001 were analyzed. 80 patients developed a surgical site infection and 121 patients developed endomyometritis. This table shows the crude hospital cost for surgical site infections compared to uninfected patients. As expected, patients with a surgical site infection and endomyometritis had higher unadjusted costs for surgical admission plus any readmission compared to uninfected patients. The attributable total costs estimated by the generalized least squares model were $3,529 for a surgical site infection and $3,956 for endomyometritis. The following picture shows a brief review of the classification of surgical site infections defined by the CDC. A superficial incisional surgical site infection involves only the skin or subcutaneous tissue. A deep incisional surgical site infection involves deep soft tissues, including the fascia and muscle layers. And an organ-space surgical site infection involves any part of the body that is opened or manipulated during a procedure, excluding the previously mentioned layers. The American College of Surgeons defines risk factors for surgical site infections and categorizes them into intrinsic and extrinsic risk factors. Intrinsic risk factors can be modifiable or non-modifiable. Modifiable risk factors include diabetes, obesity, tobacco use, and immunosuppression, and non-modifiable risk factors include age and history of a soft tissue infection. Extrinsic factors include the procedure, which would entail emergent procedure, change in wound classification at the time of procedure, or presence of infection at the time of procedure, such as chorioamnionitis, and higher complexity. The facility, which includes inadequate ventilation, increasing operating room traffic, contaminated operating surfaces, and non-sterile equipment. Preoperative risk factors include pre-existing infection, inadequate skin preparation, inappropriate antibiotic choice with regards to timing and weight-based dosing, hair removal method, and poor glycemic control. Intraoperative risk factors include duration of procedure, need for a blood transfusion, breach and aseptic technique, inappropriate antibiotic redosing, inadequate gloving, inadequate surgical scrub, and also intraoperative poor glycemic control. State, national, and worldwide initiatives have been implemented in recent years in order to promote safe surgery and reduce surgical complications such as surgical site infections. The WHO guidelines on safe surgery were developed in order to address surgical safety. By creating a culture of safety, the WHO is seeking to promote practice standards that reduce injuries and save lives. The Safe Surgery Saves Lives campaign outlines 10 essential objectives for safe surgery. Objective number 6 states that the team will consistently use methods to minimize the risk of surgical site infection. This objection includes identification of patient risk factors for surgical site infection, pre-surgical skin disinfection, antibiotic prophylaxis, minimizing contamination in the operating room, and ensuring sterility of all surgical instruments. We will spend the next 20 minutes discussing preoperative antibiotics and the changes in the recommendations that have evolved over the past decade. The goal of preoperative antibiotics, as defined by the CDC, is to reduce the microbial burden of intraoperative contamination to a level that cannot overwhelm host defenses. There are 4 principles of antimicrobial prophylaxis outlined by the CDC. The first is the use of antimicrobial prophylaxis for operations or classes of operations in which it has been shown to reduce surgical site infection rates. Second, antimicrobial prophylaxis should be safe, inexpensive, and have bactericidal activity in vitro coverage of causative organisms. The timing of the infusion correlates with the peak bactericidal concentrations in serum and in tissues by the time that the skin incision is performed, and they must maintain therapeutic levels of antimicrobial prophylaxis throughout the procedure. Before the late 1960s, most prophylactic antibiotics were actually administered at the end of the surgical procedure and were therefore ineffective. Initial studies were performed in animal models and demonstrated the benefit of administering antibiotics before wound contamination. Antibiotics that are now used for prophylaxis in cesarean deliveries are effective against gram-positive bacteria, gram-negative bacteria, and anaerobes. A variety of antibiotics have been shown to be efficacious, including cefazolin, cefotecan, cefuroxime, ampicillin, piperacillin, cefoxitin, and ampicillin sulbactam. A meta-analysis of 51 antibiotic trials confirmed that ampicillin and first-generation cephalosporins, cefazolin, had comparable efficacy when compared to second- and third-generation cephalosporins. In comparison, ampicillin has a much shorter half-life than cefazolin, and when compared to second- and third-generation cephalosporins, cefazolin is more expensive. Therefore, a single dose of cefazolin is the first line for antibiotic choice unless a patient has significant drug allergies. A Cochrane review published in 2014 evaluated the benefit of preoperative antibiotics. A total of 95 studies, including more than 15,000 patients, were analyzed. Compared with placebo or no treatment at all, the use of prophylactic antibiotics in women undergoing cesarean section, both emergent and non-emergent, reduced the incidence of wound infection, endometritis, and serious maternal infectious morbidity by 60%. The conclusions of this review support the recommendation that prophylactic antibiotics should be routinely administered in all patients undergoing cesarean section. Dinsmore et al. Performed a secondary analysis of an observational study of cesarean deliveries in 13 centers with more than 9,000 patients. Of the 9,000 women delivered by primary or repeat cesarean section prior to labor, 64% of them received preoperative antibiotics. A multivariable analysis revealed that the use of prophylactic antibiotics in non-laboring cesarean sections resulted in a significant reduction in postpartum endometritis and wound infection. In September of 2016, a landmark study, Adjunctive Azithromycin Prophylaxis for Cesarean Deliveries, was published in the New England Journal of Medicine. azithromycin was chosen as an adjunct to the standard preoperative antibiotic, cefazolin, because it covers ureaplasm organisms, which are more commonly associated with infections in cesarean deliveries than anaerobic organisms. The Cesarean Section Optimal Antibiotic Prophylaxis, or CSOAP trial, was a double-blinded, randomized controlled trial conducted at 14 hospitals within the United States. The primary outcome was a composite of endometritis, wound infection, or other infection occurring within 6 weeks. They included women with a singleton gestation, greater than 24 weeks gestation, and included women undergoing a non-elective cesarean delivery during labor or membrane rupture. Labor was defined as a cervical dilation greater than 4 centimeters, or of at least 4 centimeters, with a change in 1 centimeter and 50% effacement. And rupture of membranes of the duration was greater than 4 hours. Patients that were allocated to the treatment group received azithromycin 500 milligrams IV one time, plus cefazolin, which was the standard protocol. The results indicated the primary outcome resulted in 62 women, or 6%, who received azithromycin, and 119 women, or 12%, who received placebo. The number needed to treat to prevent the primary outcome was 17, to prevent endometritis was 43, and to prevent wound infection was 24. There were no differences in neonatal composite outcome of death or complications. One of the major limitations to this study was the exclusion of women undergoing elective cesarean delivery and patients with chorioamnionitis. In a study published in 2003 by Andrews et al., which did include both of these populations, patients with chorioamnionitis and patients undergoing scheduled cesarean delivery, similar results were noted when patients were given PO azithromycin and IV doxycycline after cord clamping compared to placebo. However, further investigation is warranted in this study population. In 1983, Cunningham et al. Published an article in the Journal for Obstetrics and Gynecology detailing the neonatal consequences of fetal exposure to maternal antibiotics given at the time of cesarean delivery. Due to the theoretical risks of neonatal antibiotic resistance, masking of neonatal infection, and interfering with a sepsis workup, the CDC published guidelines in 1999 stating that prophylactic antibiotics should be given after umbilical cord clamping. Following a meta-analysis in 2008 comparing the administration of prophylactic antibiotics prior to skin incision versus after clamping the umbilical cord, Constantine et al. Concluded that pre-incision antibiotics for cesarean birth not only decreased the incidence of postpartum endometritis and total infectious morbidity, but did not adversely affect neonatal outcome. This was further confirmed by studies, and in 2010, ACOG recommended antimicrobial prophylaxis for all cesarean births and further stated that antibiotics should be administered within 60 minutes of the start of the cesarean section. A Cochrane review published in 2014, which examined more than 10 randomized controlled trials and more than 5,000 patients, looked at the primary outcome of composite maternal postpartum infectious morbidity. This review showed that there were significant reductions in the composite morbidity for women who received antibiotics preoperatively compared to those who received antibiotics after umbilical cord clamping. Again, there were no differences in neonatal outcomes. Obesity alone may increase the development of surgical site infection after cesarean delivery 3 to 5-fold, and obese patients are 3 times more likely to require a cesarean section than non-obese controls. The excessive thickness of the subcutaneous tissue is believed to cause tissue hypoperfusion, hypooxygenation, which impedes the healing process, and antibiotic penetration. The risk of surgical site infection is also increased by the presence of hyperglycemia, prolonged surgical duration, and technical difficulties and excessive blood loss. In general, the absorption of drugs does not appear to be significantly modified by the presence of obesity. On the other hand, drug distribution into tissues is affected by body composition and regional blood flow, drug lipophilicity, and plasma protein binding. There are relatively few studies in the literature that look at beta-lactams in obese patients. There are several studies that evaluated the dose of cefazolin as a prophylactic antibiotic in bariatric surgery patients. ACOG states that consideration should be given to using a higher dose of preoperative antibiotics in patients with a BMI greater than 30 or absolute weight greater than 100 kgs. In a randomized controlled trial performed by Force et al., the dose of cefazolin was compared in normal weight patients undergoing a clean contaminated abdominal procedure to obese patients undergoing bariatric surgery. All normal weight patients received 1 gram of cefazolin, and the morbidly obese patients were randomized to 4 groups. They received 1 gram of cefazolin IM in the buttocks fat, 1 gram of cefazolin IM in the buttocks muscle, 1 gram of cefazolin IV, and the 4th group received 2 grams of cefazolin IV. At incision and closure, both blood and tissue levels of cefazolin were significantly less and lower for all morbidly obese patients compared to normal weight individuals who received 1 gram of cefazolin. Only when the morbidly obese patients received 2 grams were both the serum and adipose tissue levels adequate. Following a 4-month period when all morbidly obese patients received 2 grams of cefazolin, the wound infection rate decreased from 16.5 to 5.6%. A similar study in 2011, published in the Green Journal, suggested that current antibiotic dosing recommendations may be inadequate to achieve appropriate antimicrobial coverage. 29 patients undergoing scheduled cesarean section were stratified according to BMI class. All patients were given 2 grams of cefazolin 30 to 60 minutes before skin incision, and antibiotic concentrations were measured in adipose, myometrial, and serum samples at the time of skin incision and the time of skin closure. The mean concentration was considerably higher in lean participants compared to obese and extremely obese patients, as seen in this figure. All specimens demonstrated therapeutic cefazolin levels for gram-positive cocci, which is greater than 1 microgram per gram, and a considerable portion of obese and morbidly obese did not achieve the MIC of greater than 4 micrograms per gram for gram-negative rods and adipose samples at the time of skin incision and closure. Although currently published data are insufficient to make a recommendation regarding the weight or BMI which antimicrobial dose should be increased, it is evident from recent human pharmacokinetic studies that even 2-gram dosing is at times insufficient to provide adequate coverage in obese patients. Additional concern comes from recent updates of cephalosporin breakpoints by the Clinical and Laboratory Standards Institute, which states that gram-negative isolates that were fully sensitive at 8 micrograms per gram or less are now fully resistant at 4 micrograms per gram or greater, representing a significant change that will influence tissue therapeutic activity after preoperative antimicrobial prophylaxis. In addition, the clinical practice guidelines for antimicrobial prophylaxis in surgery recommend that adults weighing more than 120 kgs receive 3 grams of cefazolin before cesarean delivery. At the same institution that looked at tissue concentrations with 2 grams of cefazolin in cesarean section, a prospective cohort study was performed evaluating adipose tissue concentration when 3 grams of cefazolin was administered. This information was then compared to the historical cohort of 29 patients that received 2 grams in the previously outlined study. Acceptable coverage was defined as the ability to reach the minimal inhibitory concentration of 8 micrograms per gram for cefazolin. With 2 grams of cefazolin, only 20% of the cohort with a BMI of 30 to 40 and none of the cohort with a BMI greater than 40 reached the MIC of 8 micrograms per gram. All women with a BMI of 30 to 40 reached target MIC values, and 71% attained with a BMI greater than 40 attained this cutoff. Despite these findings, a retrospective cohort study performed at Johns Hopkins University and Duke University showed no difference in surgical site infections in women who received 3 grams of cefazolin compared to 2 grams. In this study, there were a total of 335 women, 160 of whom received 3 grams of cefazolin. The median absolute weight was 310 pounds with a BMI of 51. This review included both emergent and non-emergent cesarean sections, and 3 grams of cefazolin was administered to women weighing more than 300 pounds or with a BMI greater than 40. The primary outcome was surgical site infections, including superficial, deep, and organ space infections. In total, 44 women were diagnosed with a surgical site infection, and the proportion of women diagnosed with a surgical site infection that received 2 grams of cefazolin was 13.1%, and those that received 3 grams of cefazolin was also 13.1%. Therefore, the addition of 3 grams of cefazolin was not associated with a reduction in surgical site infection. The most significant contributors to an increase in surgical site infection was an estimated blood loss greater than 1,500 cc's and closure with staples, which we will discuss in the next section. One of the abstracts presented at the oral plenary session at SMFM evaluated whether prophylactic oral antibiotics following cesarean delivery would prevent surgical site infections in obese patients. The primary outcome was a surgical site infection within 30 days of delivery. This was a single-center randomized controlled trial over a 5-year period. A total of 405 women were enrolled. Obese patients with a pre-pregnancy BMI were randomized to prophylactic antibiotics, including cephalexin and metronidazole, versus placebo for a total of 48 hours postpartum. The overall incidence of surgical site infection was 11.7%. A prophylactic course of antibiotics postpartum reduced the risk of surgical site infections by approximately 60%. From 16.3% in the placebo group to 6.7% in the treatment group. And a more significant reduction was seen in patients that experienced rupture of membranes prior to cesarean delivery. The decrease in surgical site infection was 32.8% to 9.8% in the treatment group. Although there is a significant reduction in surgical site infections, there are potential neonatal adverse outcomes with administering metronidazole to women who are breastfeeding. One of these adverse effects is loose stools in the neonates. In a controlled comparative study of 35 newborns who were monitored for a total of 10 days following maternal therapy with metronidazole, they compared these women to those receiving ampicillin and metronidazole or no treatment at all. In the infants who were given ampicillin and metronidazole, they had significantly increased rates of loose stools. Summary of the University of Maryland antibiotic policy states that antibiotic prophylaxis given prior to the start must be given prior to the start of the case within 20 minutes. The preferred agent is cefazolin, and it recommends 1 gram with an increased dose of 2 grams if the patient weighs more than 200 pounds. All surgeons should double glove and remove the outer pair of gloves immediately after fascial closure. However, the infection prophylaxis for cesarean section policy is under construction, and we plan to modify the guidelines incorporating some of the newest literature. These modifications will reflect the addition of azithromycin and terminology reflected to increase the dose or redose antibiotics following an estimated blood loss greater than 1,500 cc's or a prolonged duration greater than 3 hours. In the next section of the presentation, we'll talk about surgical site preparation. These images are of Joseph Lister, the founder of aseptic surgery, and his carbolic acid spray for surgical site prophylaxis. The use of carbolic acid spray was abandoned in 1887 when Lister found that microorganisms located on the hands, dressing, and skin of patients was more important for causing surgical site infections. Quantitatively, more than 10,000 microorganisms per gram of tissue is defined as surgical site contamination, which significantly increases the risk of surgical site infection. On the other hand, a much smaller inoculum of contaminating organisms is required to cause infection when foreign material is present at the site, such as suture. For most surgical site infections, pathogens originate from endogenous flora, such as the patient's skin and hollow viscera. These organisms include staphylococcal, streptococcal, diphtheria organisms, Pseudomonas, and Propionibacterium species that are consistently present on patients' skin. The Center for Disease Control and Prevention recommends a patient shower or bathe with an antiseptic the night before the operative day and skin antisepsis at this incision site. The goal of preoperative showering with an antiseptic solution is to decrease skin microbial colony counts. Here, we use 2% chlorhexidine sage washcloths, which show a reduction in bacterial colony counts approximately 9-fold. This has been compared to povidone iodine soap, which results in a reduction in bacterial colony count by approximately 1.3 to 1.9-fold. In a Cochrane review published in 2015, which evaluated 7 randomized controlled trials over a 26-year period and included more than 10,000 patients, compared 4% chlorhexidine or Hibiscrub with placebo solution, normal bar soap, no pre-surgical wash on the night before or morning of the procedure. There is no clear evidence that washing with chlorhexidine reduces the incidence of surgical site infection. Despite these recommendations, the CDC, the CDC, AORN, and ACS continue to endorse the use of chlorhexidine cloths preoperatively because they are safe, simple, and effective at reducing resident bacterial flora. This review was strengthened by the heterogeneous nature of the population undergoing a wide variety of procedures, including clean and potentially infected patients on an inpatient and outpatient basis. But it continues to provide no evidence of benefit for preoperative showering or bathing with chlorhexidine over other wash products to reduce surgical site infections. This image is an example of the handout that the patients are provided when they present for their preoperative visit on labor and delivery. It provides explicit instructions on how to apply the wipes before surgery. The most commonly employed antiseptic agents used for preoperative surgical site preparation include iodophores, which is povidone iodine, known as betadine, alcohol-containing products, and chlorhexidine. Chlorhexidine comes as a 4% aqueous solution without alcohol, 2% prepackaged cloth for a waterless bath as described before, and 2% solution with 70% alcohol, also known as ChloraPrep. Similarly, DuraPrep is a 0.7% iodine solution combined with 74% alcohol. Each agent has a slightly different antimicrobial profile as seen in this chart. In addition to the broad spectrum antimicrobial effects of aqueous iodophores, it may also be used on mucous membranes such as the vagina. The aqueous chlorhexidine solution may also be used on mucous membranes, but it has reduced coverage against mycobacterium and fungal species. 4% chlorhexidine solution is the solution that we use on the abdomen and the vagina when indicated prior to the application of ChloraPrep. One important difference to note between chlorhexidine and aqueous iodine solution is that iodine-based solutions are inactivated by the presence of blood. Lastly, one advantage of ChloraPrep and DuraPrep is that they continue to work for 48 hours after applied to the abdomen. In a large systematic review and meta-analysis, Maywald and Chan reviewed the efficacy of povidone iodine and chlorhexidine gluconate preparations alone or in combination with alcohol. The benefit of alcohol is that it is microbiologically the most active component. However, it has no residual activity once evaporated. It has immediate and rapid bactericidal activity. The disadvantages include the dry time, which is 3 minutes or longer if it's present in the hair, and it cannot be used on mucous membranes. There is strong evidence in the literature that chlorhexidine in combination with alcohol is superior to aqueous iodoform solutions that do not contain alcohol in reducing surgical site infections. However, this superiority does not hold true for povidone iodine plus alcohol or other competitors with alcohol. The perceived efficacy of chlorhexidine is often misleading and based on chlorhexidine alcohol containing preparations, and the effect of alcohol has been overlooked. For surgery, the question of chlorhexidine plus alcohol such as ChloraPrep versus iodine plus alcohol such as DuraPrep is unresolved. One of the previous studies highlighted in the systematic review was a prospective study that compared 3 skin preparations by means of sequential implementation. These included betadine plus a single application of 70% isopropyl alcohol, ChloraPrep, and then DuraPrep in the adult surgery population. Over an 18-month period, there were a total of 3,000 procedures. The patients that were prepped with DuraPrep had the lowest infection rate, which was approximately 3.9%, compared to those that received betadine, which was 6.4%, and those that received ChloraPrep, which was 7.1%. The majority of these differences were noted in the presence of superficial incisional surgical site infections. The role for vaginal preparation has been debated, and the conclusions from the most recent literature are conflicting. All 3 of the randomized control trials presented here included women who underwent scheduled and non-emergent cesarean sections. They compared chlorhexidine vaginal scrub with povidone iodine solution to sterile water or no scrub at all. Only Abdallah found a reduction in the rate of endometritis. On the other hand, all 3 randomized control trials did not observe a difference in the overall infectious morbidity, including postoperative fever and wound infection or separation. Unfortunately, with an already labor and time-intensive abdominal scrub, it may be the best interest of time to defer the vaginal preparation without a clear benefit. There is limited information in the obstetric literature regarding irrigation of the abdomen. We do know for prevention of surgical site infection. We do know that irrigation of the abdomen can lead to increased intraoperative pain and nausea. There is some literature in the general surgery, regarding general surgery, that looks at this. In a randomized controlled trial involving children younger than 18 years with perforated appendicitis, they were randomized to peritoneal irrigation with a minimum of 500 cc's of normal saline or suction only during laparoscopy. The primary outcome was postoperative abscess, and they found no difference in abscess rates in the irrigation group versus the suction-only group. In addition, irrigation of the subcutaneous layer alone has not been studied. However, cleansing the tissue before closure does allow for better localization and control of bleeding before wound closure. At the University of Maryland, our surgical site preparation practice recommends that inpatients should be bathed the night before and the morning of surgery with 2% chlorhexidine sage cloth. On an outpatient basis, patients receive a chlorhexidine kit to complete at home the night before and on the day of surgery. And all patients undergoing a surgical procedure shall have chlorhexidine with 70% alcohol or ChloraPrep applied for skin antisepsis. The exceptions to this include exposure of mucous membranes, such as the vaginal mucosa, allergy or hypersensitivity to chlorhexidine, or an emergency procedure. Alternatives to ChloraPrep include DuraPrep, except again in emergency cases when you're unable to wait for the 3-minute dry time, chlorhexidine 2% solution for open wounds, and chlorhexidine 4% solution for vaginal mucosa. And lastly, they recommend povidone iodine for emergency procedures. It is common practice on labor and delivery that patients receive a 4% chlorhexidine wash immediately prior to the application of ChloraPrep. I was unable to find any studies in the literature to suggest an additive effect when the 4% chlorhexidine solution is applied before ChloraPrep. If we eliminate this step, we may be able to decrease our preparation time. Due to the questions that have arisen following nursing education for the new surgical scrub technique with ChloraPrep, we plan to have an informational question and answer session with a representative from ChloraPrep on March 17th. In the last section of the presentation, we'll review wound closure techniques that help reduce surgical site infection. One of the most commonly debated questions is whether non-absorbable skin staples or absorbable subcutaneous sutures are better at preventing wound infection. It has been postulated that sutures act as a foreign body and damage tissue, leading to increased risk for infection. Unfortunately, the literature available on skin closure method is inconclusive. A Cochrane review published in 2012 found no difference in wound infection between staple and subcuticular skin closure. Staples are associated with similar outcomes in terms of wound infection, pain, and cosmesis compared with sutures. Compared with absorbable subcutaneous sutures, non-absorbable staples are associated with an increased risk rate of skin separation when removed on postoperative day 3. Within this Cochrane review, there were not enough patients to analyze the effect of BMI on skin closure techniques. Following publication of this Cochrane review in 2012, a randomized controlled trial was performed at University Hospital in Birmingham, Alabama. They reported that absorbable subcutaneous sutures are associated with a lower incidence of wound disruption and infection. In a single randomized controlled trial, including scheduled and unscheduled cesarean sections, a total of 398 patients were included. Patients were randomized to metallic staples or fluoromonocryl for skin closure. Staples were removed and adhesive tape was placed on postoperative day 3 following a layered transverse incision, and postoperative day 7 to 10 for a vertical skin incision. The primary outcome was a composite of wound disruption or infection within 4 to 6 weeks postoperatively. The baseline characteristics were similar among the two groups, with an average BMI of 36. The cumulative incidence of primary composite and its components at the time of hospital discharge and 4 to 6 weeks after delivery are presented in the following table. The primary outcome at discharge was 7.1% for staples and 0.5% for subcutaneous sutures. And at 4 to 6 weeks, it was 14.5% for staples and 5.9% for sutures. The difference in the two groups was mainly attributed to wound disruption. These findings were further corroborated by a prospective multi-center randomized controlled trial over a 2-year period, which showed a 57% decreased incidence of wound complication when the skin incision was closed with subcuticular sutures rather than skin staples. All women underwent a cesarean section through a band and steel incision in this study, and the primary outcome was the incidence of wound complications, predefined as a composite of infection, hematoma, seroma, or separation of 1 centimeter or longer, or readmission to the hospital for wound complications. A total of more than 700 women were randomized, 370 to monocrol sutures and 376 to staple closure. 58 women had wound complications, 4.9% in the suture group and 10.6% in the staple group. This was largely a result of the decreased incidence of wound disruption in those that were closed with subcuticular sutures. There were no differences between the groups with respect to the occurrence of wound infection, hematoma, seroma, or readmission to the hospital for wound complications. The reason for closing the subcutaneous tissue has been postulated that it reduces the dead space where fluid and blood may accumulate and reduces the tension on the incision site. Alternatively, disadvantages to closure of the subcutaneous tissue are longer operating times and the introduction of foreign material which may be a nidus for infection. In a meta-analysis including 6 randomized control trials, they looked at the primary outcome of wound disruption. They found that closure of the subcutaneous fat offers a protective effect with a 34% decrease in wound disruption risk in patients with subcutaneous fat that was closed greater than 2 centimeters in depth. As noted in a comprehensive review by Bergella et al., Evidence-Based Surgery for Cesarean Delivery, placement of a subcutaneous drain, regardless of tissue thickness, does not appear to offer any benefit in reduction in wound morbidity. Electrocautery is expected to reduce the surgical duration because of beneficial hemostatic effects. However, electrocautery is also associated with potential complications including internal and external burns, seromas, and surgical site infections. In the first randomized control trial looking at the use of electrocautery in patients undergoing cesarean section, Moreira performed a pilot study at a university teaching hospital in Brazil. Women undergoing non-emergent cesarean section were randomized to 2 groups, those that may use electrocautery and those that may not. The patients were blindly reevaluated by an investigator on the day of hospital discharge, postpartum day 7 to 10, and postpartum day 30 to 40. At each evaluation, the surgical scar was examined for signs of infection, hematoma, seroma, or dehiscence. 97 patients in the intervention group and 96 in the non-intervention group completed the protocol. The mean BMI was 25. There were no significant differences that were found in surgical wound complications between the different groups and at all 3 different time points. The increase in post-discharge complications was similar in both groups and was in agreement with their initial with what they had anticipated prior to starting the surgery. In a randomized controlled trial published in the European Journal of Obstetrics and Gynecology, Hinkson et al. Evaluated the use of the Alexis O retractor in the prevention of surgical site infections in patients undergoing their first planned primary cesarean section compared to the traditional Collins metal retractor, which you see in the image at the bottom. The primary outcome, again, was surgical site infection. They found a significant difference in the rate of surgical site infections between the 2 groups. They found an 8% rate of surgical site infection in patients that were allocated to the Collins retractor and 1% in the group that was allocated to the Alexis retractor. Several limitations to this study included the intentional exclusion of obese patients. The average BMI in this population was 22. And the use of the retractor in the patients undergoing a primary planned cesarean section. Another randomized control trial performed by Scoleri et al. Was specifically designed to look at the use of the Alexis retractor in obese patients to reduce surgical site infections and wound disruption. Obese patients were randomized to the Alexis retractor or standard handheld retractors. In obese women with a BMI greater than 30 undergoing non-emergent cesarean section, the Alexis retractor did not decrease surgical site infection or wound disruption. Changing the outer pair of gloves and using new instruments in open colorectal surgery cases has become convention. However, there is no research to support these practices. Interestingly enough, our infection prophylaxis protocol mandates that all surgeons double glove for cesarean sections and remove the outer pair of gloves immediately after fascial closure prior to closure of the subcutaneous tissue of the skin. A small randomized study in the obstetric literature that recommends changing gloves after removal of the placenta may decrease the amount of serosanguinous drainage 24 hours postoperatively and be associated with fewer wound infections. However, this study was a small sample size and underpowered. Two larger studies included a multi-center randomized trial and prospective trial in general surgery which failed to demonstrate a benefit to changing gloves. However, multiple surgery organizations recommend double gloving in order to protect the physician so that it is easier to identify when there's been a breach in the top glove. The CDC recommends covering the incision for 24 to 48 hours postoperatively. Several types of dressings have been investigated following cesarean delivery. In a randomized control trial performed in Brazil in 2014 to 2015, patients were allocated to receive dialkyl carbomoyl chloride, or DACC, impregnated dressings, or standard surgical dressing. The DACC impregnated dressing acts by a physical mechanism of action. The hydrophobic fibers bind irreversibly to bacteria that commonly cause surgical site infections and reduce the number of bacteria in the wound bed and their proliferation. Prior to this randomized control trial, the efficacy of DACC impregnated dressings has been proven in the treatment of venous, arterial, and pressure ulcers, burns, diabetic foot, and hard-to-heal post-traumatic and post-operative surgical incisions. A total of 296 women received a DACC impregnated dressing, and 290 women received the standard dressing, which was Tegaderm in a pad following the cesarean section. The dressings were removed 48 hours post-operatively, and incisions were evaluated for a surgical site infection on the day of removal of the dressing, post-operative day 7, and post-operative day 14. There were no difference in demographics between the two groups, and the average BMI was 24 with a range of 14 to 47. Surgical site infections were observed substantially more often in the standard dressing group. Incisional surgical site infections that occurred within 14 days postoperatively occurred in 5.2% of the patients in the control group compared to 1.8% of the patients that received the DACC impregnated dressing. Of note, that the mean time of additional hospitalization in those that had a surgical site infection was approximately 8 days. Of pregnancy BMI, preeclampsia, and smoking, and the use of standard surgical dressing were associated with a notable increase in surgical site infection in a multivariable logistic regression analysis. Interestingly, in a cost analysis, the total estimated cost of a surgical site infection and treatment was greater in the control group than in the group that received the DACC impregnated dressing. The benefits of negative pressure wound therapy are widely recognized. Negative pressure wound therapy routinely used to facilitate closure of open abdominal wounds, open fractures, and skin graft sites. There is an increasing trend towards the application of negative pressure wound therapy to close an incision after cesarean delivery. The closed incision negative pressure wound therapy manages the surgical incision by reducing incision line tension, decreasing edema, and providing an airtight seal. The International Multidisciplinary Consensus, which is made up of a group of surgical and infectious disease experts, recommendations were published after reviewing a total of 100 articles which described outcomes in more than 2,000 patients, primarily in the field of general, cardiothoracic, plastic, orthopedic, and vascular surgery. The majority of these studies reported that closed incision negative pressure therapy was associated with a decrease in wound complications, wound dehiscence, surgical site infections, hematomas, seroma formation, or incisional drainage. The consensus recommendations for the most appropriate use of closed incision negative pressure therapy are in patients with one or more comorbidities or in patients with a surgical incision that is at historically high risk for developing a surgical site infection. In the figure on the screen, the blue indicates low risk for surgical site infection, while red indicates a high risk for surgical site infection. Closed incision negative pressure therapy use is recommended in patients with an increased number of patient risk factors and incision risk factors. Patient risk factors include diabetes, advanced age, tobacco use, alcohol use, chronic renal insufficiency, chronic obstructive pulmonary disease, and the presence of a hematoma. And incision risk factors include a high tension incision, repeated incisions, traumatized soft tissue, edema, or contamination. Ekbry et al. Designed a cost-benefit analysis decision tree model to determine if there's an economic benefit to the use of prophylactic negative pressure wound therapy devices on a closed laparotomy incision after cesarean delivery. The device costs approximately $500. The benefit was defined as the cost saved by avoiding surgical site infection after cesarean delivery. They found that prophylactic negative pressure wound therapy on closed laparotomies after cesarean delivery is not cost beneficial in patients with a low risk of postoperative infection. This analysis emphasizes the use of closed incision negative pressure therapy that may better be utilized on patients that are a high-risk population, such as obese patients with multiple comorbidities. There is limited research on wound care in the post-hospital setting. There are a substantial number of surgical site infections that occur after discharge, and the surgical site infection rates may be underestimated without formal surveillance. Most surgical site infections are identified via presentation to the emergency department or outpatient clinic follow-up. We now have new discharge instructions developed by Dr. Halou and Dr. Schillinger, and all cesarean patients will follow up in 1 week for incision checks. The new discharge instructions are comprehensive and provide a more detailed education to the patients regarding the type of cesarean section that they had and reasons to notify a provider. In summary, administer antibiotics before skin incision, redose antibiotics if an estimated blood loss greater than 1,500 cc's or duration of the procedure is greater than 3 hours, apply skin preparation with an alcohol-containing solution in non-emergent procedures, double glove, close the subcutaneous tissue if greater than 2 centimeters in depth and avoid drains, close with sutures if possible, consider a DACC impregnated dressing, and follow up in 1 week. Thank you. I'm happy to take any questions at this time. Yes, Dr. Atkins. I didn't see anything in particular on that. I looked more at the DACC impregnated dressing, but I can certainly look at that too, especially for our patient population. Dr. Tran? Mhm. Oh wow. Okay. Dr. Manu? Most of the literature that I read looked primarily, it didn't look at like swabbing the area after or looking at the tissue concentrations, but it looked more, I think they were targeting the ureaplasm as opposed to the anaerobes because they felt that that was more likely the causative organism of the surgical site infection. And they, in the review, they showed that the reduction in surgical site infection, but I'm not sure if there are studies where they actually swabbed the abdomen to look at what the organisms were in those studies that received azithromycin. Mm. Well, yeah, that seems to be consistent kind of with what they were seeing as well. It was mainly for protection of the surgeon, just so that you can recognize if you have a hole in your glove, but not to reduce surgical site infection. Colorectal surgery. Mm-hmm. Mm-hmm. Sure, yeah. Mm-hmm. Yeah, the one that looked at changing gloves after delivery of the placenta was just really small and underpowered, so it really didn't provide very much insight. Great. Oh, yeah. Uh-huh. So he is asking for the closed incision negative pressure wound therapy. How long were they keeping the wound vacs in place? And most of the studies that I looked at were 7 days. Dr. Koppelman?
Thank you, that was the LO I had to go home. You did mention the study. The number one paper, the article at the first conversation with the prophylaxis or antibiotics. You need to find what standard recommendations are for prophylaxis, and you consider 48 hours anything but presumptive.
So they were using patients, just obese patients. They didn't really have anything in particular in terms of, like, they did include patients with ruptured membranes, but if patients were undergoing treatment for chorioamnionitis, they were excluded from the study. So in terms of the standard of care, I think for chorioamnionitis, that is a little bit different because there's no current standard of care for treatment for prevention of surgical site infections in obese patients, but certainly 48 hours seems to be much longer than what we've ever done. Dr. Cummins? Yes.
even with our NICU moms, spend all day in the NICU and never take a shower. 4 days. I've noticed a small series of things, people coming back with Florida infections. I don't know if it's just observer bias or other people. But I think it's a real problem in the NICU.
Bless you.
Anyone else seeing this?